Hello and welcome. This is the 2024 American Psychiatric Association annual meeting, Psychiatric News Highlights video series. I'm Adrian Preda, the Editor-in-Chief of Psychiatric News, and my guest today is Dr. Helena Hansen. Dr. Hansen, can you introduce yourself and share some of the highlights about your background and how did you get interested in doing what you're doing today?
Thank you so much for having me. So I am an anthropologist psychiatrist. I did an MD Ph.D. in cultural anthropology, and then I did psychiatry as well as addiction psychiatry fellowship training. And what I have really spent the majority of my career doing is importing key concepts and methods from the social sciences into academic medicine and psychiatry, where largely they've been lacking. So it's been about a decade since in academic medicine and psychiatry in particular, we've been using the term social determinants of health to capture those aspects of a patient's exposures and life course that we actually know explain the vast majority of their health outcomes. So there's now just mounting literature documenting that if we were to choose any single thing as a determinant of mental health and physical health outcomes, it would actually be the social environmental exposures that people are subject to. It's not the medication we prescribe. It's not how often they come to visit a doctor. It's actually the conditions that they live in outside of the clinic and outside of the hospital. But yet we've made almost no investment in that over the past several decades in medicine and in psychiatry. We've really been focused very much on the individual molecular level determinants. We've been preoccupied with genetic sequences. We've been preoccupied with molecular drivers of health outcomes. And we have not turned the same investment and focus onto the social environments that people are in. And so that's one reason that we don't have the tools, actually, that we desperately need in psychiatry and in academic medicine to dramatically improve health outcomes. That comes into focus when we start comparing the US with other countries. So there are now multiple studies that independently have confirmed that the US, ironically the country in the world that spends the most per capita on healthcare of any nation, almost a quarter of our gross domestic product right now. By far we spend the most. We get the worst health outcomes of any of our 17 industrialized nation peer countries. And if we start to ask ourselves why, and we have, so for example, the National Academy of Medicine did a study 10 years ago and then replicated it just last year, showing that really we neglect the social and structural determinants of health in this country. We don't invest in community level health promotion and improvements in the physical environment, parks and rec transportation, green space. We don't invest in access to fresh and healthy foods. When it comes to public safety, we invest a lot in militarizing our communities, and we do very little, and we actually live in gated communities for the most part. We don't have gun laws that protect people from the high levels of gun violence that we're experiencing, and all of the communal fear and anxiety that surrounds the free dissemination of guns. So we don't invest in community level health promotion. That's been a missing link. And we also don't invest in our mental health research arenas. We don't invest in understanding on a rigorous and fundamental way the mechanisms by which social determinants that we kind of measure broadly at a population level, how do those actually impact mental health outcomes? What is that biosocial interface of the social environment and how it changes our brain biology, and human biology? So that is the big uncharted territory. And that's why I am so pleased with my decision to pursue a Ph.D. in social science and combine that with medicine and psychiatry, because I've been able, with a growing network of colleagues who work at this interface, to begin to import more rigorous conceptual understandings of what is the social in the social determinants that we're preoccupied with, and how does that actually influence human biology, in particular the brain.
So you brought up so many, so many very important points, and really, I think things that we need to think about in terms of treatments, but also policies. And it seems like, based on your research, one of the big questions here is when it comes to addiction, there is a tension between the nature-nurture model, and it seems like we need to think closely about how to approach the addiction model through the nature-nurture model.
Thank you for that question. It turns out that psychiatry, like the rest of medicine, has been struggling with nature versus nurture for a very long time. And it's swung the pendulum from many decades ago in post-World War II America. There was a lot of, under the influence of some psychoanalysts, a lot of attention to mothers, for example, refrigerator mothers, just the emotional style of parenting, particular with the focus on the women of the family, explains some of the psychopathology that we see in the clinic and in the hospital. And then, as of the early 80s, when the DSM-3 came out, and, kind of a cultural victory, if you will, in our profession of biological psychiatry as an explanatory model. This was the era of the Human Genome Project. A lot of excitement, enthusiasm, and expectation around being able to explain mental health outcomes in terms of our genetic code, in terms of our biological inheritance. And that's the era that I came into medicine under. That's the regime. And I think that, it's very understandable that we would want simple answers to what turn out to be very complex and intractable problems that work on multiple levels. That's where we get into a bit of a danger zone, is looking for magic bullets. And, one of the phrases that those who work in social determinants of health area research often invoke is that actually our zip code explains more of our health outcomes than our genetic code, right? Meaning that those who work in the field of social determinants research, they also reinforce a certain dichotomy that it's either or. In my current work, collaborating with life scientists, in particular neuroscientists, to understand how social environments influence the mechanisms by which social environments influence brain development and function in particular, I've come to see it as not dichotomous. I think we need to think about nature and nurture, but we need to think about both those categories in a very different way. What do I mean by that? So nature, if we step back and think about human biology, not in a very narrow way in terms of the genetic sequence, but think about human biology and brain biology as very complicated. We're a species that has evolved to respond and survive in complex social environments. So our brains are acutely sensitive to the social environment around us and adapt very quickly. And we're seeing that, for example, in research on the neurobiology of psychotherapy, where we're seeing that neuroplasticity, well documented through neuroimaging, changes in brain structure and function that happen as a result of talking with someone and simply re-narrating and re-examining and understanding in a different way, in a different frame, what has happened to me, who I am, and what the possibilities are in the future. These things lead to a change in brain architecture that is on par with that you'd see with successful antidepressant medication therapy. And actually, the two combined enhance each other. That's where the action is, neuroplasticity, epigenetics, in our understanding that it's not about the genetic code as much as how do social exposures, the social environment, influence what the genetic code is producing in the way of proteins. That's another area where we're seeing the human brain is exquisitely sensitive to social environment, and actually our brain biology changes and adapts to social environment. The microbiome, gut-brain interaction. We're understanding now that actually we have a lot of receptors that we think of as neuroreceptors in our gut, and that our gut is actually what receives the environment. So environmental exposure, a lot of it goes through our gut in the form of the microorganisms that colonize our gut, and that these have a tremendously strong impact on our brain function and brain chemistry. So these are all areas, and not to mention climate change. Okay, this is an era of climate anxiety, number one. So our psychiatric colleagues working at this interface are noting that not only is environmental destruction and climate change a real source of distress, psychological, psychiatric distress, but patients who are getting treated for psychiatric conditions are much more heavily affected, for example, by heat waves. So the medications they're on often impair their ability to regulate temperature internally. And so it's our patients that die off disproportionately in heat waves. It's just one example. So there's so many different ways that we are in psychiatry needing to leave behind outdated, very unidimensional and linear models of brain biology and go for these much more complex, interactive, ecological, if you will, models of our brains in reaction to and also for helping to form the environment, the social environment, and even the natural environment around us. So nurture versus nature has to be nurture and nature in that way, because nurture and nature interact with each other and form each other. So that's what I call the biosocial moment that I believe is where we need to go. And those of us who are collaborating with brain scientists are actually beginning to go.
One of the things that impressed me in your lecture today was your experience during your addiction fellowship. State-of-the-art biological therapies are available, but also you talked about the garden therapy. Can you tell us a little bit more about that and how that may be informed? Some of the ways you think about the nature and nurture interaction.
Thank you for that question. Yes. So one of my most formative experiences, starting off in my addiction psychiatry fellowship, and then, 2 decades later, I still was active in this garden, was seeing the immense power of a garden, which was planted right outside of the hospital between Bellevue Hospital grounds and the FDR highway, on land that the hospital had originally said was not suitable even for parking. So the clinic director, Dr. Anatina Misher, and patients and staff side by side, they got donations of soil and seed, began to plant and cultivate. And, I arrived 25 years into this, actually, at Bellevue. They'd already been cultivating and harvesting this garden for over 2 decades. It was the foundation of so many connections between people that lasted well beyond patients' time in the clinic, cultivated a lot of sustained networks of recovery support and mutual aid. It was a physical place that people would come to celebrate anniversaries, birthdays, holidays together. Many of the people that we saw in Bellevue's outpatient addiction clinic had been alienated from their families. Many of them had been without stable housing for a really long time, were referred to us from the homeless shelters in the area. We're so isolated. And, we're only now beginning to recognize isolation. Social isolation is a major driver of negative health outcomes. Our Surgeon General right now has declared loneliness an epidemic and a driver of the mental health crisis. But at the time, when I, 2 decades ago, began working in this garden, what I saw was that it was serving to connect people. It was also a place where people who didn't respond to traditional one-on-one talk therapy and clinical sessions could work the land physically side by side with their therapist and have a very different kind of conversation and interaction that led to breakthroughs in treatment that hadn't been possible in the more traditional model. And each person could see the results of their cultivating and tending plants, and there was a kitchen in the clinic as well where people learned to prepare the produce that they'd grown, not to be taken lightly in a society where the younger generation as a whole doesn't know how to cook. But many of our patients were coming from shelters and just hadn't even been in a kitchen with access to a kitchen for a long time. So learning to feed themselves was both symbolically important, but also actually important for their nutrition and their biology. Right. So this garden was both a metaphor and a material place where people could cultivate a very different kind of existence for themselves. And, you were asking about nature versus nurture and addiction. At the same time that I was working in this garden, I was participating in the evolution of the very field of addiction medicine. So I came into Bellevue right as at that point it was called the opioid crisis. The opioid crisis was taking off. And I saw the evolution of addiction medicine as a whole cohort of well-insured, more affluent, largely white Americans who had been touched by the prescription opioid epidemic because they were the ones with access to prescribers, and they were the target of very aggressive marketing of this new class of opioids, newly patented expensive opioids that were promised to be less addictive, less harmful than other opioids on the market. This was a crisis that was seen as largely a white crisis, and it was responded to very differently than other drug epidemics. We're in a country that has for many decades espoused a drug war mentality, criminalizing and incarcerating people who use drugs. And in this case, the response was to criminalize the prescribers of the opioids through prescription drug monitoring programs and so forth. But for those who'd been getting the prescription opioids or using the prescription opioids, a whole new field of addiction medicine opened up, and private office-based maintenance treatment with buprenorphine, otherwise known as Suboxone, was created and legalized. So I saw this unfold in front of me, along with a reframing of addiction as a chronic relapsing brain disease. And this was intended to take the stigma out of it, to really squarely define addiction as a brain and physiological based problem, not something that a person's moral character should be blamed for example. So that took off, this idea of addiction as a brain disease, and then running side by side a discourse of deaths of despair. That if we look at the other part of white America that was so heavily marketed to and suffering such high rates of opioid overdose, working class, blue collar, small town, and rural America, they had also had the new expensive opioids marketed to them and insured through workers' comp, for insurance plans for just manual laborers. We see a deaths of despair discourse cropping up that, white Americans their life expectancy is dropping, largely because of drug overdose, followed by suicide and liver disease, and that it's directly correlated to deindustrialization, the export of working class jobs and manufacturing, construction and mining elsewhere, high unemployment rates, the disintegration of civic institutions as a result of eroded employment and tax base in these small towns. So there's a deaths of despair discourse that also was a non-criminalizing, non-blaming discourse for drug addiction, focused on white America in a moment that opioid overdose was seen as a white American problem, seemingly at odds with chronic brain disease model, but both kind of evolved side by side. And what was left out of that was a whole segment of the American population, Black and brown Americans, for example, who continued to experience very high incarceration rates on drug charges, with the peak of incarceration in this country already the world leader in rates of per capita incarceration, peaking in 2008. So well after the beginning of the opioid crisis, drug use and substance use disorder criminalized still in those communities, Black and brown communities, where Black Americans 6 times as likely as white Americans to be incarcerated, but not more likely to use drugs. So that's a long-winded way of saying that we've had these very different ways of explaining addiction and framing addiction, otherwise known as substance use disorder in its medicalized moment, depending on who the subject is. And so that's yet another area where a biosocial lens is incredibly important, because understanding the racial politics of U.S. drug policy and the racial politics around U.S. drug development, medication development, and marketing, understanding how all those forces come together is necessary to explain the patterns of overdose deaths, which is a very biological outcome. So that's another place where the biosocial is critical for understanding and then addressing the outcomes that we see.
So it seems like the biopsychosocial understanding could be done almost, the right way or the wrong way. So the wrong way meaning we can understand, for example, addiction as a social issue, but that could result in actually it's because of moral failings, and that would result in criminalizations, as opposed to understanding the social determinants of addiction or mental disorders. Or on the biological side, we could understand, that there is maybe, there are some alterations in terms of brain function circuitry, or we could say that that's something that happens in the social context, meaning that there is still some agency, as opposed to the brain is ruled by the disorder, and there is nothing to do other than prescribe some other biological intervention that's going to fix the damaged circuit. So extreme biologization will take away agency, right? And we could think of social interpretations and understandings that would result in, instead of understanding, actually a more problematic conceptualization, such as criminalization of addiction, or the moral failings of people who have severe mental illness.
You make such an important point in that in our efforts to relieve people of the blame of, in one instance, addiction or substance use disorder, in other instances, other mental health conditions, mood disorders, psychotic disorders, in our attempt to destigmatize that and, giving a biological explanation, at the same time, we're taking away major routes to intervention. And that's why it's so important to pay attention to the social environment and also how that is cultivated through places where people can connect with each other and make meaning of their experience. Those of us who've been involved long-term with patients who are in successful recovery from not only substance use disorder, but psychotic disorder, mood disorders, a whole host of conditions, post-traumatic stress disorder, we have seen how critical it is for them to foster supportive connections with other people, and often through mutual aid kinds of relationships, peer support, as well as supportive professionals, relationships with supportive professionals, and also making meaning of what they're experiencing. Understanding, in the words of those of us who do trauma-informed care, what happened to you? Not just what are you, but what happened to you? Starting with the assumption that there is something that brings us to this, and we have a history, and that we can also alter the course of our personal history. We do have agency, that we can foster health-giving relationships. We can get involved in health-promoting activities, such as gardening, such as creating art and music. That's another thing that happened in this wonderful clinic that I was involved in. The arts are not to be minimized, just enhancing and tapping into people's creativity. Creative arts and making objects also feeds into creativity and reinventing one's own path in life, reinterpreting the experiences and the symptoms that we've had. So those ways of reinterpreting one's life, that's a form of agency that we owe it to our patients to help to support. And we have to create environments that they can walk into that will foster that. We have to create gardens and art studios and community organizations and partnerships with community organizations and arts organizations. We owe it to our patients to make sure they have that available to them. I call these social technologies. They're not molecular. They don't seem as high technology as a pharmaceutical or biotech device, but they actually have tangible effects, and when they're successful, they're very deliberately and skillfully crafted by people who've spent their careers studying and refining their practice and their knowledge base. So that's where we need to invest our time. And that will lead to a much more profound destigmatization. My sociology colleagues have studied the biologization of mental health problems ranging from schizophrenia to substance use disorder to actually test the assumption that defining a condition as biological will destigmatize it. And they found that it actually has the opposite effect, for the reason you just mentioned, that people who learn that a condition is biological will also read into that it's fixed, it's unchangeable. And they'll worry about heritability. So if they're asked, well, would you invite someone like this into your family? Would you want, your eligible son or daughter to know someone with this condition and potentially marry that person? No, this is a biological heritable condition. I want to be as far away from that as possible. So ironically, that the idea of a mental health condition as biological can actually foster the marginalization of the people involved. We don't want to blame them for moral failings. We know it's all about what's happened to you, It's about the environment that you're in, as well as your biological susceptibility at baseline. But what we can do is destigmatize through mutual aid, recognition that all of us have struggled on some level and that mental health is a continuum, and to break down some of those very sharp distinctions between people who are psychiatric patients and people who aren't, because so much of what our patients are struggling with is a part in some way of the universal human experience. Yeah. We all have some glimpse into an experience like that. The vast majority of us have had very low mood at some point in our lives. The vast majority of us have statistically experienced hallucinations at some point in our lives. We can empathize with others. And so it's that spirit of mutuality and that leveling, that this is a condition we're all in as humans. That is what helps to destigmatize mental health conditions.
Yeah. You've talked about so many things, like, which one should I ask about? So let me go back to a point that you made, which I think is so well said. You talked about gardening as a way of cultivating oneself. And that's metaphorically and really, as a matter of fact. But I think that's such an important thing to do, which is kind of tapping into this complementary nature-nurture paradigm as opposed to an opposite nature versus nurture. Because cultivating ourselves is in fact getting in touch with everything else, as opposed to expanding, let's say, narcissistic way. You don't care about the others. It's a connected way of being in the world. And kind of that makes me actually wonder about another thing that you mentioned, which is the value, the importance of peer support. Peer support is very different than the one-to-one therapy that we do with our patients. Do you think that what makes peer support different actually has value, a different value than just therapy in the classical sense, in terms of helping people who are somewhat disconnected, isolated?
What a fantastic question. I have from the beginning of my psychiatric training, been so impressed by the power of peer support. It really is nothing like hearing from somebody who has really been in your own shoes with a given psychiatric condition. How did they evolve in their thinking about it and how they addressed and managed it? Seeing living proof in front of you that the condition can be managed and that you can have a happy life. We've all, as psychiatrists, had that experience of a first diagnosis moment where an individual and their families often are devastated by a diagnosis, right? And the first thing that crosses a person's mind when they get a diagnosis, say, of a serious psychiatric condition is, my life is over. There's not a way out of this, right? So we've all seen that despair. And we can tell them as professionals over and over again, no, there is hope. But the thing that really gets that across is meeting somebody who's literally been there and who has had to work hard to arrive at a different way of seeing themselves, managing their lives, and who has found a way of being in the world that's satisfying, even if they continue to have symptoms. I think in psychiatry these days, we're very preoccupied with getting rid of all symptoms. That's not necessarily the thing that leads to a fulfilling life for many of our patients who go on to flourish in their recovery. And I'll just give a quick example of an organization called the Hearing Voices Network, which has gotten a bad rep as being, quote unquote, anti-psychiatry. I guess the implication is perhaps against medications. That's not necessarily the case. Hearing Voices Network is a group of people who experience psychosis, who began meeting together for mutual aid, to give each other hope, to share stories of living successfully in the world with a psychotic disorder. Some of them use medications, a great many of them do. But the point of the group is not to just assume that the voices are a random symptom that needs to be stamped out. This group actually seeks to understand their voices. It eventually seeks to befriend their voices. Many people who've gone down this path have discovered that they had experienced early in their life a profound traumatic event or more than one traumatic event, and that they began hearing voices that in their own way were trying to protect them. So the paranoid voices that many of our patients hear are actually an attempt for the mind to protect itself. And so this is a group of people who've learned to make sense of the voices in a different way. Very often our patients, even with the best of psychotropic medications, can't eliminate voices, and that may not actually be the only goal here. The goal is really to live successfully. And so that's just, Hearing Voices Network it's a model of another way of approaching life as somebody with serious psychiatric symptoms. It's really, how do you live successfully? And that can only really come across in a mutual aid, peer support setting, as much as we try as professionals to get a message across. So I think that what you put your finger on is something very powerful. It's an incredibly powerful tool. I'm not sure we've figured out yet how to manage it as a field in psychiatry. There are more and more states, New York State included, and also my home state now of California, have provided in state-level Medicaid programs for reimbursement of trained peer mental health support workers. So that's a step in the right direction. But we're beginning to see there are a host of other issues that we'd have to confront head on and work in an earnest way to address. Underpayment of people in this category of employment. The fact that many of us as psychiatrists don't know how to interact with peer mental health specialists as colleagues. They're not patients. They may have had lived experience. They may have living experience of serious psychiatric conditions, but they are experts. They have their own expertise. So they are expert and professional contributor to our care team. And not all of us as psychiatrists have really been socialized to understand that and to know how to take advantage of their expertise. So we have a ways to go in fully incorporating peer mental health workers and really making use of that moment of mutual aid and of the hope that can be instilled by someone who has successfully navigated a serious psychiatric condition. But it's well worth the struggle because this is a powerful tool.
It's a very complex reality, and I think one of the things that unfortunately drives the care in the United States, as you know, is that we are facing a landscape of fragmented insurance coverage, and at the end of the day, finances are irrelevant. So in this context, lots of challenges, opportunities.
So you want me to comment on the opportunities in front of us?
That's right.
That's the note that my lecture ended on today, which was I had a very astute question about healthcare financing. How can healthcare financing better embrace and support a biosocial approach that includes a lot of community-level peer support, use of the arts, gardening, whatever tools are available that under what I call social technologies. And that is an uphill battle. I will admit this is not a linear thing. We have a healthcare system that stands out globally as being the most expensive and the least effective on a population level. The highest percent of our GDP of any country spent on healthcare, the worst health outcomes, including mental health outcomes of any of our 17 peer industrialized nations. So this is a difficult nut to crack. And one of the reasons is there's so much money involved in a healthcare system that's very privatized and profit-oriented, and where healthcare industries have a very large political influence. So this is hard. Over many decades, our forebears have tried to enact some form of health reform that would lead to more universal coverage and some cost controls on the private industries that really have full say in charging whatever the market will bear. So this is a tough nut to crack. However, I think we're standing at a big window of opportunity to change the way that healthcare is financed and what kinds of interventions take priority in our healthcare system, especially in mental health. Why? Because we're in a self-declared and widely recognized mental health crisis. We're seeing just record rates of suicide and other serious psychiatric conditions. The interface of COVID, global as well as local political upheaval and economic threat. Young people now are faced with a level of anxiety about their future and the future of our planet and climate change that is kind of unprecedented. So we're seeing a huge mental health crisis with all of a sudden much more attention to why and much more attention to the need for investments in mental health promotion and care, and a recognition that the models that we've been using up until now have not served us. So it's not a happy thing that we're faced with this level of mental health crisis, but what's accompanied it is a much more active interest in mental health and much more open conversation about mental health and the appropriate response than we've seen in many, many decades. Mental health is no longer the stepchild hid in the closet, and more willingness to put public resources towards mental health care and promotion. So that, along with an admission that our model has served us very poorly of mental health care and promotion, that's a big window for us to step in with a new paradigm, such as the one that I'm calling biosocial, to call attention to investments in community-level health-promoting environments. Everything from gardening and the arts to housing policy, housing as healthcare. We see, especially in mental health, but also in physical health, how incredibly strong stable versus unstable housing is as a driver of health outcomes. So we're having much more open conversations about housing policy as health policy, along with many other things. Our educational system, our criminal legal system, all of these things drive health outcomes and are worthy of attention as a part of health policies. So I think this is a big window of opportunity, even though the route to getting there is not going to be linear. It's not going to be easy at all. It's going to require a lot of struggle. But it's in that struggle that I see us as psychiatrists getting our professional satisfaction. Psychiatry leads among many other medical specialties in dropout from clinical practice and burnout. We're just seeing record levels of burnout and dropout from clinical practice. Psychiatrists lead, but there are many other specialties that are reporting the same thing. When interviewed about why, psychiatrists and other medical specialties, people in other medical specialties report that they're very frustrated by the systemic barriers to improving their patients' health outcomes. Flip side of that, my colleagues who study the impact of different ways of training and educating practitioners have found that if you teach about social determinants of health without giving tools to intervene, you increase burnout. But if you pair teaching on social determinants of health with tools to address them, how can you partner with housing agencies? How can you partner with schools? How can you advocate for better policies that are health promoting for your patients? How can you partner with community-based organizations to foster networks of social support and mutual aid, even in churches, and temples and in faith-based organizations? If you give practitioners those tools, then they report much better satisfaction in their work. It's actually being able to address the problems at their root cause that gives us the professional satisfaction that we deserve, and that also keeps us engaged in mental health care and keeps us from leaving the profession. So it's in the struggle, actually, that we get the satisfaction. We just need to know how to direct our energies. And if we bring those two things together, the wide open window right now to get much more public support for mental health care, both political and symbolic and economic, that along with the satisfaction that we can have as psychiatrists who shoulder to shoulder with community organizations, leaders in other sectors, and patient groups, psychiatrists who are willing to fight for that, to advocate for that, for a much more comprehensive approach to mental health promotion and care. That's where we get our satisfaction and can survive as a specialty.
Dr. Hansen, I want to thank you for your wonderful insights and
you.
also for your foundational work in helping us better understand, I think, not only addiction, but severe mental illness. And thank you for taking the time to participate in this conversation today.
Really enjoyed it. Thank
you.